important. I think as ophthalmologists we all treat glaucomas, but sometimes we actually mistreat them because we don't know what is causing the rise in IOP. And again, she had mentioned that angle closure is a very important disease as far as we are concerned. Most of the hospital statistics have shown, whether in North India or South India, that 50% of the glaucomas that we see in India are actually angle closure glaucomas. Most of the time it's primary angle closure, and if you consider that if you had done a gonioscopy when the patient was first seen, you would know it was an angle closure, you would do an iridotomy and prevent any further angle closure from occurring. So giving medication to control the IOP is not what you need to do in an angle closure eye. What you need to do is to first diagnose the glaucoma and then be able to quickly do an iridotomy so that the angle closure doesn't continue, and whatever you need to do in terms of controlling the intraocular pressure to target IOP therefore becomes much more meaningful. I'll just step back a little bit, and if you look at the diagram shown over here, basically what we're trying to say is that the first time you do a gonioscopy, you're not really sure what you're looking for. So people who are planning to learn how to do gonioscopies, as Sushmita had said, please try and do it on aphakic eyes or even pseudophakic eyes because they tend to have a deep AC. And what you have to know is the anatomy. So if you look over here, you can see that this is where the Descemet's membrane actually ends. This is what we call the Schwalbe's line. And the trabecular meshwork is actually much more anterior than what we think from the ciliary body. So if you look on gonioscopy, you're going to be looking for the Schwalbe's line. You're going to be looking for the anterior trabecular meshwork, the posterior trabecular meshwork, the scleral spur. Then you're going to be able to identify the ciliary body in an angle which is wide open. On the other hand, if the angle is more narrow like this, you're probably only going to be able to see the Schwalbe's line and maybe some part of the anterior trabecular meshwork. Alright? So just again to reiterate, basically what we need to identify is a landmark. And the most important landmark, and something that you can see in every single patient that you want to do a gonioscopy, is the Schwalbe's line. So again, this is what we are looking for, and you can see that this is where the cornea ends, and this can be identified very easily by using a very thin slit, a very bright slit, and then you can see where the corneal wedge actually is. So at this point where the anterior and the posterior surfaces of the cornea no longer become visible, that means the two anterior and the posterior surface fuse, this is the Schwalbe's line. And if you do this before you do anything else, you will find that identification of the Schwalbe's line helps you to identify what else there is. So that is our anterior margin. The second thing we want to identify is where is the iris. So if you look at that, these two, you can see for yourself what a distance there is between the Schwalbe's line and the iris. So you're reasonably certain that the angle is wide open. Again, this is an anterior segment OCT picture. This is again to remind you that what you're seeing as the corneal wedge is this clear area. This is what is seen clinically. Alright, and this is the other thing that you're likely to see. So you have an anterior margin of the angle and a posterior margin of the angle. And if you look at it end on, again you can see that this is where the corneal wedge is formed. This is your Schwalbe's line, this is the iris. And you can see that they are much closer than in this picture where they were quite a distance away. Okay, so if we keep that in mind, alright, what we are aiming to do is try and see what is the distance or what is the angle formed between the most peripheral cornea and the most peripheral part of the iris. Alright, so we start here. We have a light beam, and you can see that the light beam has two edges. So you choose for yourself whichever is sharper, and you look at that. Look at the edge on the peripheral cornea, and you look at the edge on the iris. And the angle that appears to form over here is almost 40 degrees. Okay? You're then going to try and see what Sushmita had said as a white line, and you can see the white line very clearly here as the Schwalbe's line. And you can see the iris is down here. So there is a wide area of the trabecular meshwork visible between. Now when we come to this patient, you can see that we are following one edge of the light again. You follow this edge and it seems to go here. but it's not actually in continuity over here. So there is a parallax. that means it tells you that the light is actually falling behind and you are not able to see the light as it goes behind this iris. So it looks as if the angle over here is probably about 25 degrees. Does that make sense? Is that easy to follow? Especially the residents, I can see some young faces over here. Does that make sense to you? Yes? Follow one edge of the light beam. Okay? Here on the other hand, you can again see that this is the light beam going over here, but the iris seems to be almost in contact with that light beam. Alright? And you can see that the angle is extremely narrow, possibly about 10 degrees. So just again to reiterate, what we are measuring is the most peripheral, the angle between the most peripheral cornea and the most peripheral part of the iris, which is this. This is the angle that we are trying to measure, and this is called the angle reset. To judge a patient as having an occludable angle, what you have to see is that the posterior trabecular meshwork is not visible over at least 180 or 270 degrees of the angle. It's something that is highly debatable, because if it's not visible in one quadrant, why would it be visible in the rest? But these are the definitions that have been given. Alright? And the other thing is that most angles which are less than 20 degrees are those that are most likely to close. This black arrow in all these slides is just continuing to show you the Schwalbe's line. So if you keep looking at it, and with a little imagination, you can see that there's a white line here with a little bit of pigment anteriorly. Similarly, again, you can see this is a white line here with a pigment anteriorly. So you can see the anterior trabecular meshwork, but you're not seeing the posterior trabecular meshwork. Similarly, here you can just about see the anterior trabecular meshwork, but nothing else is visible. This has already been described. These are two ways in which you can actually see over the convexity of the iris to the area of the trabecular meshwork. And though this is supposed to be video gonioscopy, I've always found it difficult to explain to people on a video gonioscopy. So I've just broken it up into photographs. So we have this one patient in whom there's a light beam that is shone, and if you notice, the light beam is very short. So the light beam should actually be only 2 millimeters in height, alright? Just about reaching the iris and reaching the peripheral cornea. So what you can see over here again with a little bit of imagination is a white line over here, and you can't see too much of the trabecular meshwork, definitely not the scleral spur, definitely not the ciliary body. So what you then do is you narrow the slit, and on narrowing the slit you can see that the anterior and posterior surfaces of the cornea are meeting over here, again the white line. And as you narrow the slit, you can see that the angle will become even narrower. Look at this angle and look at this angle. This is exactly the same eye. The next couple of minutes, you can see the angle narrowing because the light is not reaching the pupil. The light has become smaller. So you're identifying the Schwalbe's line and you're looking at the angle form. It's about 10 to 15 degrees. If you now widen the slit, or if you allow it to touch the pupil, you can see that I've now lengthened this. This slit was short, 2 millimeters, I've now lengthened the slit. Immediately this convexity of the iris tends to become flat. Is that visible? Yes? So immediately it becomes flat and you can start beginning to see the trabecular meshwork. But when you are identifying angle closure, this is not what we want. This is the end of your examination. What we want is this, a very thin slit, 2 millimeters in height, helping you to identify the Schwalbe's line, helping you to identify how far the iris is from Schwalbe's line. Okay? It also then tells you what is the angulation at the back. Okay? So this is showing you what happens when the light reaches the pupil. Immediately it flattens out, you can see more of the angle. So if you had started like this, you would have said this patient has an open angle, just give prostaglandin, just give timolol. On the other hand, when you do this, you know that there is a possibility of closure, or he's possibly had closure and desperately needs an iridotomy to do a good management. Okay? And here, ultimately, when you widen the light out, you can see that there are a number of blotchy pigments that are seen in this particular eye. Again, there are angles and there are false angles. Alright? So just to highlight the fact that you can see, again, this is one patient. Here's the black arrow showing you where the Schwalbe's line is, and the iris seems to be very close. When we widen the slit, you can see that the angle opens up almost completely. Here's your white line, the Schwalbe's line. and the angle is widely open. So this is an occludable angle, but there's no evidence of closure as of now. On the other hand, you see an angle like this, and you can see that there's a brown pigmentation in front. I can tell you half my residents would probably say this is the trabecular meshwork and the angle is wide open. But actually what highlights the fact is that there is no parallax between the light beam as it comes here and as it goes over the iris. And however much I try to open it up, you can find that the angle doesn't open. So this is a completely closed angle, and the pigment dispersal anterior to the Schwalbe's line makes it look as if the pigmentation is a trabecular meshwork. Alright, so just going through a few things that we expect to see once we've decided that the angle is occludable. We now want to know has at any time angle closure occurred? Because 1/3 of us as Indians walk around with an angle of less than 20 degrees. But only 1% of us thankfully develop angle closure glaucoma. Alright, so the 29% you're going to actually distinguish by saying, is there evidence of closure? As you can see, here's Schwalbe's line. I keep telling you, the black arrow is the Schwalbe's line. So here's Schwalbe's line, and you can see the iris being tented up. Can you see that? There's a little hill that you can see over there. It's being tented up and it's stuck over here. So we have what is called a synechia over here. On the other hand, if you look here, you can see these little filiform synechia. They're little fingers. This was a lady whose mother had angle closure glaucoma, and she said, I brought my mother in and we said, why don't we check your eye out? And this is what we found in her eyes. So these are filiform synechia that are the first evidences of angle closure. On the other hand, you can sometimes just see these blotchy pigments. Can you see this? These blotchy pigments are not the pigmentation that we, as Indians, we are a pigmented race. So as Indians, all of us over the age of 40 are likely to show you some amount of pigmentation, but it's a diffuse pigmentation in the inferior angle. So if you see something like this in the superior angle, especially if it's blotchy, can you just see this? One here, one here, one here. This tells us that at some point the iris was in contact with the central cornea. Part of the stroma has been left behind, and then the iris has fallen back. Okay? Here are other evidences of synechia. But if we were looking at the previous one, you can see that the Schwalbe's line was visible, and these synechia are all below the Schwalbe's line. So these are what we would call goniosynechia or iridotrabecular synechia, as compared to this, where you can see that it is going all the way up to Schwalbe's line. Alright? So this is what we would call iridocorneal synechia. Alright? These are commonly seen with acute angle closure or sometimes with uveitis. Okay? Gonioscopic recording you can do any way you like, as long as you write the parameters that are important. I think Shushmita has already said this. What we insist our residents also do is to try and determine what they think is the angle in between the most peripheral cornea and the most peripheral part of the trabecular meshwork, and we make them record it on a diagram like this, so we know in 360 degrees how much of the angle is open and how much is closed. It's something we try very hard to do. It's not always possible. Again, just to end, please see that there are more things than relative pupillary blocks. So we've got this patient who looks as if, this is a small, as you can see, a 2 millimeter angle. And you can see that the Schwalbe's line is there and the iris is here. It seems to be quite open. When you actually do an indentation, again you can see, as she has shown you already, a double hump pattern. So this double hump is caused by the edge of the lens and the COD process pushing the iris up. Don't forget that there are many reasons for secondary angle closure, the commonest of course being neovascular glaucoma. You can see the ectropion uvea, and if you look carefully, you can actually see some neovascularization in the angle. You can sometimes have iridoscheisis like this, which can occur idiopathically, and sometimes it can occur as part of angle closure disease itself. Here you can see the NBI very clearly. You can see the neovascularization coming from the iris and going all the way up to Schwalbe's line. Or you can get other reasons for angle closure, like this melanoma. You can also have anterior chamber IOLs pushing the iris onto the trabecular meshwork and then producing enough inflammation to cause synechia. You can see also that there is an extensive amount of pigment that is visible. So I'd just like to say that gonioscopy is indispensable if you're going to be treating glaucoma. Just keep 2 or 3 things in mind when you do it. You must know what you're looking for. You must have an anterior border, you must have a posterior border, And two very easy things to identify are Schwalbe's line and the iris that you can see. Between these two is your trabecular meshwork or whatever is visible of the angle, and therefore you then have to determine what is the angle between these two structures and what is the visibility, so that you can actually say, out of the 30,000 or whatever, 30 million people that are roaming around with narrow angles in this country, only 1 million are probably going to need an iridotomy, and you identify them properly. Thank you very much.